The coronavirus, or more specifically, SARS-CoV-2, has been with us for upwards of 6 months now. It has impacted, among other things, our children's education, our small businesses, our entertainment, our social lives, and of course, the health of our communities. It has been so eventful that 1 in 9 Americans say their lives have changed at least a little as a result of this illness, including 44% who say their lives have changed in a major way. Welcome everyone, I'm Will, and this is The People's Health. Today's topic is, what does this virus tell us about how our communities are built, the services within them, and how understanding this contributes to this ongoing discussion about social justice. Let's get to it. What these 6 months have allowed us to do is observe trends, and among the most devastating of those trends is the extent to which Black, Latinx, Indigenous, and immigrant populations have been disproportionately affected by this virus. According to the COVID racial data tracker, Black people are dying at rates almost 2.5 greater than white people. The Latinx population in Florida, despite only being a quarter of the population, make up over 40% of the cases. In Arizona, indigenous communities make up 4% of the population, yet 12% of the deaths. So what accounts for these disparities? Why is this happening at this rate? What is it about Black and brown communities that makes the result of the data so disproportionate and them so affected by health inequity? Well, part of the answer is structural racism. Structural racism in our built environments and the access to health within those environments. But what does that mean exactly? Looking at this country as a whole, we can see where our society has failed. It has failed where urban planning, public health, and social justice meet. Urban planning is defined as the design and regulation of the uses of space that focus on the physical form, economic functions, and social impacts of the urban environment, and on the location of different activities within it. In simpler terms, an urban planner is one who develops plans or designs for the use of space by cities, towns, and developments. Basically, the built environment. Public health is defined by the CDC as the science of protecting and improving the health of people in their communities. Communities in this country aren't built with those two ideas in mind anymore, but that wasn't always the case. These two topics have a history together. In the mid to late 1800s, during the Industrial Revolution, cities in the US and Europe were experiencing a huge boom in population. As more and more Americans moved to cities, contributing to urbanization, the prevalence of disease in cities hit crazy levels. Due to poor housing conditions, inadequate sanitation and ventilation, and dangerous working practices in cities, urban populations were suffering from illnesses such as cholera and typhoid as waste pooled in the streets from the lack of sewage systems. In 1864, John Snow, not that John Snow, yeah, that one. This guy successfully mapped a cholera outbreak in London and changed how city officials approached health and urban planning. By the early 1900s, advances in the field of public health had begun to focus on something called germ theory. Still accepted today for many diseases, this theory states that there are specific agents of infectious disease, in particular microbes or microorganisms known as pathogens, and how these agents invade the body and cause specific diseases. Public health research shifted from investigating ways to improve urban infrastructure to laboratory investigations of microbes. Interventions were then focused on specific immunization plans, with physicians, not planners, emerging as the new class of public health professionals. As these two fields separated further, urban planning began to focus on things like zoning to protect urban populations from things like industrial pollution, and at times to keep certain people in certain areas away from other certain people. Not to mention, the focus of urban planning has almost exclusively been economic ever since. Public health took on the role of addressing the host of disease rather than the environment as a whole, thinking that the task was much too broad and difficult to tackle. During the mid-20th century, it changed further as the field of public health largely ignored the social dimensions of disease and emphasize instead on modifying individual risk factors that were reflected in people's lifestyles, such as their diet, their exercise, and whether or not they smoke or drink. And so here we are today. Systemic health and social inequalities that have been with us for a long time have put many from racial and ethnic minority groups at an increased risk of getting sick and dying from COVID-19. Disparities in social determinants of health have historically prevented these communities from having fair opportunities for economic, physical, and emotional health. These historical barriers influence a wide range of health and quality of life outcomes. These then become factors that contribute to an increased risk of COVID-19. The CDC has identified 5 factors which we'll get into in future episodes. They include discrimination, healthcare access and utilization, occupation, educational wealth and income gaps, housing. These factors and others are linked to more COVID cases, hospitalizations, and deaths in areas where racial and ethnic minorities live, work, play, and worship. They have also contributed to higher rates of some medical conditions that increase people's risk of severe illness from COVID-19. So what can we do? This pandemic has changed the way we communicate with each other, the way we connect with each other. Communities have responded to recommendations and circumstances with social distancing, school and work closings, now openings, all of which have brought their own unintended negative impacts. It is important for all of us to lean on and support each other. The CDC says community and faith-based organizations, employers, healthcare systems and providers, public health agencies, policymakers, and others all have a part in helping to promote fair access to health. To prevent the spread of COVID-19, we must work together to ensure that people have resources to maintain and manage their physical and mental health, including easy access to information, affordable testing, and medical and mental health care. We need programs and practices that fit the communities where racial and minority groups live, learn, work, play, and worship. And that last part is the most important. We need programs and practices to prevent these kind of disparities from continuing to occur. So what this channel is about, it's about bringing awareness and advocacy to the topics that surround urban planning and public health. Basically, the built environment and the health of the people that live within that environment. In future episodes, we're going to cover things like racism, housing, poverty, crime, and illnesses such as asthma and tuberculosis, and the prevalence of these illnesses within our racial and ethnic minority communities. We're going to discuss how all of these topics are connected in some way or another to the overall topic of the built environment and public health. In the end, I hope that all these discussions about structural racism and disparities that exist within this system can contribute to some way to social justice or the conversation about social justice occurring in our country today. I hope that you can all join me as we explore these topics together. If you have anything you want to share, including some topics you might want to see on this channel, don't forget to leave a comment below. Also, more importantly, don't forget to subscribe. Click on the bell for notifications for new episodes and like this video. I'll see you again in 2 weeks. I'm Will, and this is The People's Health. Don't forget, take care of yourselves and each other. Peace.